My name's Tom Ford and I'm the chair and organiser of Grand Rounds. February is LGBT month. Every year that we've been doing Grand Rounds, well, certainly for the last 5 or 6, I suspect, I've been asked to allocate one of the Grand Round presentations to the topic of LGBT, and we've had some of our best talks, I think, certainly some of our most thought-provoking talks over the last 6 years from a variety of internal and external speakers, covering a range of issues which are relevant to everybody, but perhaps come from a LGBT slant. You'll remember last year we had a talk from a plastic surgical colleague talking about availability of gender reassignment surgery, and we've had talks about research into the bias that people have towards appearance in people who are transgendered. This year, I'm very pleased to welcome back recurring speaker Sarah Allstaff, who has been a staunch supporter of Grand Round since the start. And she's going to... Well, I asked her what she was going to talk about last week, and she wasn't entirely certain. But what she's come to us with is moving from don't ask, don't tell to we'll tell, just ask. A talk which is relevant to everybody in all of our work and our personal lives as well. And she's going to reveal to us why, on honeymoon in San Francisco, she suddenly realised that she was a fully out member of the LGBT community, and perhaps why we should be too. Sarah Allstaff, everyone.
Spontaneous round of applause. So don't go anywhere. How do I do that?
Okay. See, I've already screwed something up. There we go. The weight of expectation. There you go.
Lovely. Hi there. Thanks all for coming. I was really not sure of what kind of turnout I'd get. And when I arrived to just one person, I was a little bit crestfallen. But thank you for coming. Here we go. Moving from don't ask, don't tell to we'll tell, just ask. Tom promised you photos of cats and cushions, so here we go. My cat, Richie, just in case any of you had to leave early if I do go on a bit. There you go, there he is. And with the rainbow cushion, I feel is very topical. Richie is both a lover and a fighter. Right, so what is LGBT History Month? So, as Tom said, it takes place in February of every year, and really it raises awareness of prejudice, and victimisation of people who belong to the LGBT community. It also celebrates achievements that have been made and also celebrates diversity. So it's a bit of a protest as well as a celebration. And it culminates in Purple Friday, which is tomorrow, the last Friday of the month. Why purple? Takes us back to the LGBT flag, which I don't know if you know the history of it, but Gilbert Baker designed the LGBT flag in 1978 in San Francisco. And what I hadn't been aware is that each of the colours of the flag have meaning. And so we have life, healing, sunshine, nature, harmony and spirit. So Purple Friday is really about the spirit of LGBT History Month in the LGBT community. So if you were to come to our department tomorrow, if you haven't heard this joke, where have you been? But here we go. I work in the sexual health clinic, which should not be confused with the discharge hub across the hall. I roll that joke out every presentation I do. So anyway, if you were to come to sexual health tomorrow, what you will find is us mostly eating purple-coloured foods and also getting a bit silly with the silly string. So if you are at a loss for what to do tomorrow at lunchtime and drop by the clinic, there will be sure to be food. Right, again, in traditional style, my disclosures. I am no expert on LGBT issues, all right? And it actually took me a long time to, A, figure out whether I was going to do this at all, and B, whether what I was going to talk about. I went through all manner of things, and I can assure you it took me every ounce of strength to not talk about syphilis. But I'm not going to do it. I didn't even say it. Rash. It's everywhere. Test right. So I'm not an expert, but I am comfortable with LGBT issues, so I think that's reasonable. And as such, as not being an expert, I'm liberally borrowing other people's work, but I believe I have duly referenced it. And lastly, almost lastly, I am cisgendered and heterosexual. All right, I had a thought, really, should this talk be delivered by somebody from the LGBT community? And as a cisgendered heterosexual, is it really my place to give this talk? For those that don't know, cisgendered means that the gender you were assigned at birth aligns with the gender that you identify with. And as you can see from the above photo, I am the chubby one in the pink cap. I was assigned female at birth. That being said, the one in the blue cap is also a girl. Anyway, I was assigned female at birth, and I am married to that fine specimen of a man sporting a Seahawks cap just for Tom. So, lastly, despite being cisgendered and heterosexual, I do believe I am a member of the LGBT plus community, and I'm here to out myself publicly as such. So yes, I was on my honeymoon in San Francisco, and I took a little walking tour of the Castro. I do say I because my husband wouldn't join me. He was to be found in a sports bar in proper masculine style. He was not going to go with me. Anyway, I met a little group at Harvey Milk Plaza. Harvey Milk in 1976 was the first gay person to be elected to public office in California, but was actually later assassinated by a former police officer because of his standing up for LGBT issues. Anyway, there we are, Harvey Milk Plaza, when a woman with a ukulele sang a song that I'm not going to repeat, but she basically told me what all the plus stood for, that LGBT was more than just lesbian, gay, bisexual, transgender. There was a number of other groups that are probably very poorly represented. So transsexual, queer being quite an umbrella term. A lot of people who also belong to other of these groups might define themselves as queer, just being different. It used to be quite a derogatory term, but I think it's now in fashion again, although it's probably something that people would choose to use to define themselves, but not be defined by other people. Questioning, intersex, ally, asexual, and pansexual. So just in case there's any doubt as to where I fit into this community, and don't ask my husband, but stop there. So there I am. I'm an ally, all right, and I'm a proud ally. And so I think that's really important. I have a friend who I care very much about, despite what I'm about to tell you, who said to me recently, she was talking about this LGBT nonsense, and she said they should really call it S-, as if straight people are excluded from this community, and I certainly don't feel excluded at all. I feel very much a part of the community, and I love it. It's an awesome place to be. So I'm speaking to you as an ally. Final disclosure, most of the discussion will be about lesbian, gay, and bisexual. There's less written about transgender and even less written about other groups. So please excuse me for mostly speaking about LGB rather than the rest. So there's the photographic evidence of me being an ally for last year's, the year before, 2018's inaugural Pride event in Dundee. NHS Tayside went with ally t-shirts, and we were asked on a number of occasions all through the day who ally was. So we've sort of abandoned the t-shirts, but anyway. So an ally is somebody who supports equal rights, gender equality, and supports LGBT movements. And allies challenge homophobia, biphobia, and transphobia. All right. So the purpose of this presentation is really to explore the value in knowing your patient's sexual identity, gender identity. The term sexual identity is really that sort of box that people put themselves in, the gay box or the straight box, etc. I think more we're talking about sexual orientation in terms of you may identify as straight, but actually you may have partners from the opposite sex. So we're going to explore that value. We're going to identify barriers to establishing that information from your patients, and maybe talk about some practical solutions, and also touch on how we teach LGBT, and also how can we assess competencies against LGBT core knowledge, behaviours and skills. That's obviously a minefield, and certainly my reading has in no means been complete, so again, forgive me for that. Right, is there value in knowing your patient's sexual and gender identity? What do you think? Do you think it's relevant for your patients, for your relationship with them? Naturally, there's a right answer here. But I can imagine you may not think it is. And patients may not think it is as well. So how big is the LGBT population in the UK? Well, the Office of National Statistics tell us that 2% of the general population in the UK identify as LGB. And that's identifying as that sexual identity rather than necessarily the gender of their sexual partners. There's a higher proportion of men identify as LGB than women. And a higher proportion of younger people are more likely to are more likely to identify as LGB than older groups. And we have seen an increase in the last 5 years in Scotland of people identifying as LGB. The graph here is from NatSal, the National Attitudes Survey and Sexual Behaviours and Attitudes Lifestyle. They do that every decade across the UK. They sample a general population and they compare the different cohorts. And if you look, this doesn't work. The white circle is the population. The paler circle is the number of people who have had same-sex contact, and the inner circle is same-sex sexual contact with genital contact. And you can see that difference in women over 3 successive cohorts that is quadrupled in terms of women reporting same-sex sexual contact. So it is changing, and it's probably also about it's safer to disclose your sexual orientation than it used to be, so that's part of it, as well as what we think is change in sexual behaviours. So we do have a large population that identify as LGB, but also a larger population that may not identify as LGB, but do have same-sex partners. Is your patient's sexual and gender identity relevant to their health? Well, we know there's a good amount of evidence that sexual identity or sexual orientation is a health inequality. We know that there's a higher burden of mental health problems, including self-harming, depression, and higher rates of suicide in people identifying as LGBT. We also know that they use more substances. They're more likely to smoke, they're more likely to have alcohol problems, and they're more likely to use illicit drugs. And that's part of a risk-taking pattern of behaviour, which is also true in terms of sexual risk-taking behaviours, particularly in men who have sex with men. And another thing that I think contributes to the mental health is social isolation, particularly for older people who identify as LGB, who've maybe never been able to have a partnership or a relationship, have never been able to be out, and may live alone and experience an awful lot of external and internal homophobia. And because of these health inequalities, there is some evidence that LGBT people experience higher rates of ischemic heart disease, COPD, lung cancer, and there's no doubt about the increased risk of STIs, particularly in gay men. Why does this happen? What has happened to cause this? Why do LGBT people experience this health inequality? There's a couple of theories, and both are probably true. The idea of minority stress, the idea of that internalised homophobia, having to conceal your identity, having to the trauma of coming out and the trauma of coming out repeatedly to different people, and the impact that has on your mental health and your risk-taking behaviour. The fundamental cause theory is that people who are in a privileged position are maybe better resourced to look after their own health, that there's less barriers to accessing good healthcare and risk reduction prevention interventions. So people who identify as LGBT are maybe less likely to get timely health care. And as such, the compounded stigma, so not only are you dealing with your LGBT status, but also your substance use and your mental health problems, etc., that will further cause you to not want to seek health care. And so that compounded stigma and discrimination results in reduced health screening. We know that lesbian women are far less likely to be up to date with their smears. There's healthcare avoidance and higher rates of preventable disease. So hopefully that's convincing you that your patient's gender identity is relevant to their health, particularly when we're talking about unpicking it and preventable disease. Is your patient's sexual and gender identity relevant to their experience of healthcare? And this data is from a Stonewall survey in 2015. 57% of health and social care practitioners don't consider sexual orientation to be relevant. Furthermore, almost a quarter of patient-facing staff have heard their colleagues make negative remarks, basically make homophobic remarks about LGBT people and trans people. And most worryingly, 5% of patient-facing staff, you can imagine what the volume of that is in the UK, 5% of all health and social care staff have witnessed colleagues discriminate negatively against LGBT people, treat them differently, offer them a different and worse level of care. That's a huge number across the NHS in the UK. I'm going to read a quote to you from Unhealthy Attitudes. This is one of our peers in the South East. He's called Donald. "The needs of others that are not the norm, in my opinion, should not be forced upon others that choose to be what we have up to now considered mainstream normal. As human beings, we are biologically programmed to function in a certain manner, and deviations are not to be considered mainstream society." He's one of us. This was interesting, although I didn't like the way that they phrased these questions, because it's that kind of negative question. Practitioners who say they do not consider sexual orientation to be relevant to one's health needs. So doctors were least likely to say that it was not relevant. All right. On the other hand, doctors out of all of these practitioners felt it was most relevant. All right. And when we look down to the graph at the bottom there, practitioners that say they are not confident to respond to the specific care needs, although doctors feel that it's most relevant, they also disclose high rates of not being confident. All right. Although I don't know whether that reflects maybe a little bit of intuition, because we have a lot of people, a lot of groups here that believe it's not relevant, but actually feel pretty confident to deal with it, which I think is probably incongruent and maybe demonstrates a lack of insight. So as doctors, most of us do think it's relevant, but we don't feel confident to address the issues. But furthermore, it's relevant. We kind of think it's relevant. We're not sure how to cope with it. But I think we have a responsibility to understand our patient's sexual and gender identity. So the GMC says that we must adequately assess the patient's condition, taking account of their history, including the symptoms and psychological, spiritual, social and cultural factors, their views and values, and where necessary, examine them. All right. So it's really important that we do understand the patient in the context of who they are and in the context of the life that they live. And we must treat patients fairly. Furthermore, it's written in law that not only do people from all of these groups can expect equal rights, but further, public services are required to promote and demonstrate equality. This is a measurable outcome. All right, this is something we have to be able to demonstrate. We have to be able to monitor and demonstrate concordance with. So yes, it's not and one of the words I can't bear in the LGBT realm is tolerance. This is not about tolerance, all right? If somebody told me they tolerated me, I'd be pretty upset about it, all right? This is about promoting and embracing the differences. So, moving on to the patient-doctor relationship and how these things come up. And I was reading about the patient-doctor relationship possibly for the first time since medical school. And it's a minefield. But when you think of the relationship, it's pretty messed up in terms of the balance of power, the expectations of each other, the transactional sort of element. I'm going to come, you're going to do what I want, you're a means to an end, etc. Or actually at the end I'm going to pretend to care, but actually I get paid for this and I wouldn't do it if I wasn't paid, etc. It's quite a dysfunctional relationship to an extent. What is the relationship? Is the relationship a process? Is that the means to the end? Or is the relationship actually the outcome? That's where therapy takes place, is within that relationship. Anyway, a bit philosophical. But basically we know that the medical history is the cornerstone of care. All right? And, I'm still of the firm belief that William Osler said, listen to the patient, he's telling you the diagnosis. 90% of our diagnosis is in the history. The examination and the results are really just to confirm what you already know. I'm a firm believer in that. And so the medical consultation really is about gathering information. It's about developing a therapeutic relationship and communicating information. But if one of these things doesn't work, then the others don't work. All right? If your patient doesn't tell you the information, you can't have that therapeutic relationship. You can't have that trust. So when you give them that information, they may not do with it what you wanted them to do with it or what you expected they would do with it. So it really is important that the information you get is accurate. And there's lots of techniques we've learned over the years in our careers in order to establish that. But there are barriers that exist for LGBT people to disclose that. So that patient-doctor relationship is all the more important for vulnerable people. And that's really tricky because we all know those difficult patients that are often vulnerable, and they're the ones that we really have to engender that trust with. So what do patients want? Do they want to tell us, or do they want to keep it private? We'll go on to that in a wee second. But what patients want out of a relationship, this was a piece of work, a sort of synthesis of qualitative information about the patient-doctor relationship and the patient's perceptions of the doctor-patient relationship. And basically, as you improve consultation experience and longitudinal care, so continuity of care, you get a depth of a relationship that is characterised by knowledge, trust, loyalty and regard. And when you look into this, it's not knowledge, academic knowledge, it's familiarity. It's about knowing and being known. Patients want to know their doctor and they want to be known by their doctor. Just to roll out an old cliche, that people don't care how much you know until they know how much you care. All right, so that's what patients want, is that knowledge. And they want trust. I think that's fair to say. Loyalty is an interesting one because actually patients have a strong sense of loyalty to their doctor regardless of experiences of poor care and regardless of the times that we mess up, that they actually, and you know the number of patients that come to you and complain about their GPs, and you suggest they might change their GP, but they won't change the GP because there's always been their GP, so they couldn't possibly go anywhere else because of that sense of loyalty there, that somehow they owe their doctors that relationship. And also regard. Patients actually want to be liked by you and me, in the same way that we quite like to be liked by them, but that's what patients want. They want approval, they want affirmation, they want validation from us. And I think that's a two-way thing as well. So each of these elements has two sides: the patient's opinion about the doctor and the patient's perception of the doctor's opinion of them. That's really important to them. And so when you come to consultation, you obviously make judgments about the doctor. You know, we talk about that all the time in clinic. I'm telling students how to not be judgmental. But actually our patients judge us, and we have to understand that and overcome that. So when a patient comes to see me, they see hopefully what they think is a cisgendered woman. They see a wedding ring, so they might assume I'm married. They will probably assume I'm heterosexual. They know that I've got a weird, slightly posh, weird internationally accent, so they'll decide that I'm middle class, I'm a doctor, so I'm clearly educated, and I have to overcome all of these barriers if I want this person with mental health problems and substance misuse problems, and who may be participating in behaviours that they think that I will disapprove of. I have to overcome that really quickly. So we have to scrap all of these barriers. And it's easier for me because people are coming to sexual health clinic, they know what I'm going to ask them, and they've probably already prepared that, but they're not going to be expecting that with you. So I think your job is bigger or greater in terms of breaking down those barriers. So let's talk about those barriers. Hetero-normativity, it's one of my favourite words. You say it 3 times, it belongs to you. So there's your challenge, use it 3 times and it's yours. So here's a letter I received a number of years ago about a patient. This is a paraphrase of the letter, but it's pretty spot on. Thank you for seeing this 24-year-old man who has been diagnosed with HIV infection following multiple episodes of shingles. He denies injection drug use. Read between the lines, he's lying. He denies injection drug use. He appears heterosexual because he accidentally forgot to wear his chaps that day. And I presume that is how he acquired his infection. Many thanks, yours sincerely. All right, so had he asked the patient's sexual partners are men? And, you know, he wears jeans and T-shirts and, you know, trainers and that. So, and just an aside for medical students, or anybody actually, if you're presenting a case or you write in an essay, denies or admitting, I will haul you over the coals for that, all right? The terms denying and admitting belong in courtrooms and not in the medical consultation, all right? Patient, you know, denies smoking, eventually admitted to nurse that he smokes 20 cigarettes a day, you know? To rephrase that, the patient thought you were really judgmental and wouldn't tell you that because they thought you would disapprove of them and actually felt a bit safer with the nurse. That's the truth of that story, all right? So if you say denies and admits, I will ask you why they denied and what was it about the consultation that made the patient feel that they couldn't tell you. Because I think when patients don't tell us information, it says as much about us as it does about them. Rant over. Okay. I have other handy tips for medical students as we go through. Heteronormativity is the belief that heterosexuality, predicated on the gender binary, is the norm or default sexual orientation. All right, that we just assume that people are heterosexual until proven otherwise. Okay, it assumes that sexual and marital relations are most fitting between people of opposite sex. Donald, the doctor from the southeast. Heteronormativity. All right, that's the default option. That's normal. Everything else is not normal. And heteronormativity, as I say, is a two-way street. I had an interesting chat yesterday with a couple of the obstetricians, gynecologists. People assume that we're, they make assumptions about us in heteronormativity. And it's interesting when it comes to sort of intimate examinations. So I was going through security at Schiphol Airport a few years ago, and something beeped, and I had to be taken into some cubicle and examined further. And naturally, it was fine. It's fine. Naturally, it had to be a woman. Now, the woman, I would have thought, again, I don't know, I would have thought, based on her appearance, that she fits many of the stereotypes of a lesbian woman. And I thought, is this a gender issue that I have to be examined by somebody of the opposite gender, or is this a sexuality issue? Because what if it was a gay man? Would that be appropriate to examine me? You know what I mean? It's a bit odd. It's the same in our setting, in obs and gynae, where you do, and sexual health, where you do intimate examinations. Some people will decline a male practitioner, although actually in our case it's very, very uncommon. But that's this presumption that they're straight, and also a presumption that they might have some untoward, the word, that they're badness, and also that it's fine for me to examine a woman without a chaperone, again based in the context of heteronormativity, because they assume that my sexuality won't be a conflict there. All right, so this heteronormativity is a two-way street and really affects the way that we interact with our patients because of our assumptions of their sexuality, but their assumptions of ours. And I think being out as a gender or sexual minority at work is a whole other can of worms that we're not going to follow. But it's food for thought how that heteronormativity plays into our everyday practice. What do you think? Do patients want to disclose? So I've got here a study from an emergency department in the States. The proportion of doctors who believe patients would refuse to disclose versus the proportion of patients that would actually refuse to disclose. What do you think for a proportion of doctors who believe patients would refuse to disclose out of 100? 70%. Can I get a higher or lower than 70%? Huh? 50%. So we're going lower. Was it Bruce Forsyth did that? Higher, lower. Yeah. Cars. Yeah. Any? Not bad. You're not bad. Pauline's definitely closer. And I'll show you in a second. Proportion of patients that would refuse to disclose. What proportion of patients do you actually think, if they were asked their sexual identity, would refuse to disclose it? Zero? Any higher?
10.
Good. Pretty good. Very good, actually. So yes, 80% of doctors thought that their patients would not want to disclose their status. However, only 10% would. All right. So our perception of that, I think like I said before, patients want to be known. They want to be familiar. They want to be truly understood and truly heard by you. And so all of these things we think are private, because they're private to us in the context of that relationship. We don't need to disclose it to them in this dysfunctional relationship we have with patients. But it's really important to them that they're known. So barriers, there's loads of barriers to both inquiring and also disclosing. And I put the green ones, I think this is the patients ones. So they're less likely to disclose if they also belong to another minority group, particularly black and ethnic minority groups. If they're also gay, they're far less likely to disclose. All right. Fear of discrimination, and that's based usually on past experience of discrimination. patients want to be approved by us. And if they come across Donald, for example, they're unlikely to disclose because they're going to get disapproval. All right, and they don't want to be disapproved. They'd rather be accepted and liked. They worry about confidentiality, what happens to this information. And it might depend where they are. If they're in an open ward, that might be different than when they're in a sexual health clinic behind a closed door with soundproofing, etc. And also what relationship they already have with that doctor. If they already know you to be somebody who's very open and very friendly and not surprised by stuff, then they're maybe more likely to tell you. But there's also lots of barriers from our point of view. Again, embarrassment. Well, what's the right term? What do they call it these days? They keep changing what they call it. What I'm going to call it. These kinds of things. Time constraints. Actually, I don't want to open that can of worms because I'm running late. I don't want to offend the patient by asking. Most patients are straight, and if I ask them about their sexual identity, maybe they'll think that I think they're gay, and then there's going to be so I'll just not ask. Again, perceived relevance, lack of training, appropriate recording systems, which we'll talk about. So lots of barriers that I think we just have to get over. But there's lots of things that we can do to facilitate getting over these barriers at organisational level, at our service levels, and at the individual level. So we're starting at the individual level. And just really basic things, visible. How do patients know that you're okay, that you're safe, that you can be trusted? All right, that you're going to listen and that you're going to care anyway. So, visible signs. And I don't know if any of you saw Matt Hancock yesterday. He was wearing his little LGBT NHS lapel badge. Presumably he's now about to fund PrEP in England 3 years after we have. Probably not. So that's one thing you can do. And the free swag, the stuff that you were promised, although I didn't think I'd get this level of turnout and there might not be enough for you, but I have some ally badges, all right? I have these little badges on my lanyard. I have a trans ally and I have an ally badge. And again, it's just that little sign that I see you, I know you, you're okay, I've thought about you, and you can speak to me, all right? So visible signs, you can get these NHS lanyards. We have them in our department, but they're pricey and we have to pay for them ourselves. But a lot of us do because we care that much. This is a whole mindful, again, the way that we talk, so the use of inclusive language. Right, medical students, are you listening? If you go into an OSCE station and put out your hand and say, "Is that Mrs. Smith?" I will bring you down, all right? We don't, unless we were told on the sheet at the front, the station, that it's Mrs. or Mr. or whatever. You don't say it, all right? Don't presume somebody's marital status, and don't presume that you know how they want to be addressed. We're all professionals. You go in, "Is that Jean Smith? How would you like me to address you?" And that's it, all right? Don't assume anything. And one day I'm going to write an OSCE station that's like, the patient's title is like, "The Right Honourable Reverend Doctor," just so that when somebody goes in and says, "Is that Miss?" they say, "Actually, it's the Reverend Right Honourable Doctor." And then, anyway, so don't presume a title. And ask about partners. Don't ask about husbands and wives. All right, ask about partners. They can tell you if it's their husband or wife, and feel free to refer to them as they've referred to them, but don't presume that it's a husband or wife. And until you know that somebody's gender, use a gender-neutral pronoun, so they or them. All right. So when patients tell me about their partners, they'll chat about their partners, and I still haven't ascertained if it's male or female. And so I'll say, "And how are they? Do they have symptoms, etc.?" Until I understand the gender of that partner. Don't use words like preference. For example, in pronouns, amongst sort of trans friendly services, we try to talk about pronouns that we would use ourselves. And some people will say preferred pronouns. Try to just say pronouns, because it's not like I prefer she. Because if you called me he, that's, not my preference, but actually it's really not my preference. My pronoun is she, all right, or her. So what's your preferences? Being gay isn't a choice, all right, so lifestyle choices, although it may sound quite polite, try not to talk about that. That's just who people are. Use open questions. So don't maybe try to label people or try to guess their label. Use open questions. So how do you describe yourself? All right. What terms do you use? And that's the same maybe when you see somebody who's trans, rather than trying to presume things about their anatomy or whatever. Tell me a bit about your journey so far, and they'll fill you in. And don't ask intrusive information that isn't required. You know, if you're seeing somebody because of their broken foot and they're trans and they might be on some sort of medical treatment, but it's probably not important that you know what type of bottom surgery they've had. All right? So don't ask intrusive questions just because you kind of want to know. I can't stress this enough. Don't use LGBT terms in a derogatory manner. All right? Things are not gay, and doing things like that is not gay. And we should, and not only don't use it, but call it out. All right? These are not terms that, you know, that's not a term that we'd like to use in this organisation. Why don't you say that activity is really stupid? You know, but call it out. And also don't worry if you get it wrong. It's okay to make mistakes. And maybe when you head out of here with your new vocabulary, you might try it out and it may not go that well. I make mistakes all the time. I had a transgendered man in my clinic needing PrEP, and because of the different kinetics, dynamics, kinetics, the way the drugs are handled in the body between men, between cis men and women in the studies is different, and so the dosing schedules are different. And so trans men have to follow the dosing schedules that have been established in women. And I was trying to explain this to this trans man, that he couldn't use his PrEP the same way as some of his peers would. And I said because the studies were done in men. And then I felt absolutely dreadful, because what I meant to say, or what I should have said, was the studies were done in cis men. All right? Because he's a man. That's how he identifies. And I excluded him from that group by saying the studies were done in men. So you do get it wrong. Normalise the use of inclusive language. This was my email to Tom with my blurb, and you will notice that after my name and my little red ribbon, that I have she and her. Is that because I worry that people are going to misgender me? Is that because, just in case Tom wasn't quite sure where I was with my gender today, that I would put she and her? No, it's to normalise it. And again, if people do receive emails from me and they have trans experience, they might think, she knows my language, she understands. All right? Again, normalising it, opening up the conversation. People might come to me and say, why have you got that on your email? And we can have a discussion about trans language and inclusive language. We'll see. I mean, I have been to meetings where the meeting starts with that, introductions around the table, and it's becoming normal to say, I'm Sarah Allstaff, consultant in GU Medicine, my pronouns are she and her, etc. And that's what would go around the table. Oh, there we go. Call out homophobia. Not only do you not have to be gay to call out homophobia, I think it's our responsibility. It should not be the responsibility of a minority group to call that stuff out. All right? I think we have a responsibility to call that out. So, organisational and service level facilitators to overcoming barriers to disclosure. Strong leadership. These initiatives really have to be actively led. And I also suggest they don't have to be actively led from within the LGBT community. All right? I think it's really important that this is mainstreamed. And I think people from the LGBT community, or who identify as LGBT, take a lot of that on to significant personal cost. And I think that we have a responsibility, all of us, to work together and provide leadership around that. And certainly as consultants, I think, as doctors, we're all leaders. We have to have policies that are visible, so posters up. I think that's important. But I think also our policies need to be audited and monitored, and I don't think we have means of doing that here at NHS Tayside, as far as I'm aware. I think we have to invite the community in when we design policies, and also have a zero tolerance, an enforceable zero tolerance approach to homophobia. And regarding that, this is our hallway in the sexual health clinic, if you've never been. And as Tom alluded to in his email, yes, my house has appeared in a couple of magazines. I like to think I'm a bit of an interior designer when I'm not taking photos of my cat. And I would not have designed this. This is dreadful, these flags. This is awful. However, A, pick your battles, and B, the patients love it. And the number of patients that have commented on the flags. And in fact, one became quite emotional, just seeing the trans flag. We hadn't said anything, we hadn't done anything, but that flag said, "We see you." All right, you're welcome here. Recording systems that normalise data collection. And GPs in here may be able to correct me, because I know the last time I checked, although that might not have been long ago, the only way you could document your patient's sexual orientation on a GP record was as a problem or as a diagnosis. I'm thinking, is that still the case? Yeah. 2020. There's no means of recording that, all right? And this is track. I did this sometime between 5 and 6 this morning. But you can see we're collecting religion, preferred gender of care provider, whether they're VIP or not, their armed forces, their occupation, all that relevant data, but we haven't established their sexual orientation, all right? And again, one of the easy ways to collect that, well, I'll show you what we do in our sexual health clinic here. So this is the secrets of the sexual health clinic that we keep all under the radar so nobody can see it. We have a registration form, and I've zoomed in on that little area there, your gender identity, male, female, and within that do you identify as trans, and if it's something else, tell us what it is. And what I like about that is trans isn't a separate gender. It's within male, it's within female. And the gender of your partners. All right, don't label yourself. Just tell me who you're having sex with. Although I had a student with me recently. I don't know if they're here, but I had a patient. I picked up the form. What is the gender of your partners? Male and female. Perfect. So, not a surprise to me. I do this all the time. So I go in and I take the sexual history, etc. Recent sexual history, all females. Okay, fine, no problem. And so I do my sort of catch-all questionnaire at the end where I go through everything they've ever done in their lives, including have you ever had sex with another man? And he said no. And I'm thinking, how else can I ask this question? Because it does make a difference. So eventually I just showed him the form and I said, on this form here you've written that your partners are male and female. And he said, oh, I thought that said the gender of your parents. So, yeah. There we go. So, training and accreditation is the last thing that I've put here for overcoming barriers. So pride in practice is I think maybe more an NHS England thing, and I think it's a training and accreditation programme for primary care providers. But in Scotland we have the LGBT Charter, which is administrated through LGBT Youth Scotland, and you may be aware that the Medical School Undergraduate Office got their Foundation Award in 2018. The coroner, they have a silver award last time I checked. Drumroll, please. But Sexual Health and Bloodborne Virus in Tayside got their gold award in 2018. So there's us receiving the gold award. Naturally, there was cake. And so that programme took us through a lot of training, particularly fairly intensive training on trans issues, reviewing all of our policies, making sure that they were trans-friendly and LGBT-friendly, looking at all of our paperwork, so that registration form would have been redesigned in light of that, looking at all of the information that we give to patients, non-genderising it as much as possible. I mean, in a leaflet about bacterial vaginosis, do you really need to be referring to the fact that it's a woman? But really? So that kind of thing. It was a very, and there were screeds of evidence that we had to provide, but I think it was a really good exercise to go through, even as a service that pride themselves, I think, in being quite LGBT friendly anyway. It was useful for us. Here we go. A quote: "The culture of the NHS as experienced by LGBT people reflects the attitudes and beliefs of the people who staff the NHS. NHS organisations cannot merely reflect prevailing UK cultural norms, like Donald. They have a duty to deliver services, employment and training without discrimination. And remember, it is the organisation's responsibility to come out as LGBT friendly rather than the individual LGBT person." Lastly, I think I'm doing fine for time. I really didn't think I'd be able to fill half an hour, but here we are. How do we equip tomorrow's doctors to care for LGBT patients? This is I read this paper from a medical student who's also a journalist, and I was quite moved by a lot of it, so I'm just liberally quoting her here and there. "I've never seen myself in the medical curriculum. I've never caught a glimpse of myself as anything other than a statistic. However," this is tough to listen to, "however, we are so much more than dehumanised stereotypes trotted out around tired tropes of mental health, sex, drugs and HIV. Teaching can be delivered in a way that makes sex and gender diverse students feel exposed, embarrassed, ashamed and marginalised." And actually, I've had feedback locally to that subject, where because I think a lot of LGBT issues come up in our lectures about STIs, and because it doesn't come up elsewhere, LGBT people, particularly gay men, are left feeling quite vulnerable and quite stigmatized. And that's an error, that's a mistake, we failed that group of students, I think, students and patients. So what might be required? I am not a med ed person, so I don't know this in depth. However, I think that there needs to be an LGBT curriculum running through. I don't think it's a main strand like prescribing therapeutics, but I think there needs to be a woven element of that through the curriculum. And I think that there also needs to be clear outcomes, which are knowledge-based attitudes as well as competencies. And I think we need to be able to assess that, and I don't know how. I think we need to unlink LGBT teaching exclusively from sexual health and ethics. All right? I would like to see an OSCE station where somebody is just gay. And it's not a clue. It's not a sneaky little thing to throw you off and diagnose them with HIV. They have dyspepsia and also they're gay. Yeah? They've broken their ankle and also they have a same-sex partner. So I'd like to see that more and more, where we normalise this, and that it's not a thing. It's not the problem. All right? And that's going to require faculty development as well as development of clinical staff. And I think it also needs to be further than just medicine. It needs to be integrated into all health and social care training curricula. I was I mentor new consultants in my specialty across the country, and I was one of the very few bits of wisdom I could give to a mentee recently was, don't suggest anything if you're not prepared to be landed with it. And so I did think twice about suggesting this. Again, in the words of Amy Coops, discrimination is about so much more than explicit displays of bullying and harassment. It takes root in the silences of omission and assumption and flourishes in spaces left by the unspoken and unseen. All right? So in omitting addressing these issues, we are actually discriminating. So, you'll be pleased to know, in summary, LGBT groups carry a disproportionate burden of poor health. Clinicians lack the confidence to talk about it. But we have a responsibility as individuals, as clinicians, as doctors, as services, as organisations to promote LGBT-friendly care. But we do have a need for comprehensive and specific training, and that's clinicians as well as undergraduates. But if we can facilitate meaningful disclosure of sexual and gender identity, we might actually be able to improve patient care and outcomes and reverse the systemic and structural roots of LGBT health inequalities. So, are you out yet? And if so, please feel free to pick up an ally badge. And also join us at Pride. I think that it's September again. We've had 2 now in Dundee, and they were surprisingly awesome. And so far, 100% of Dundee Pride events have been fully sunny and lovely weather. So it's an awesome place to be. And unlike maybe the wider society, the LGBT community will embrace you with very open arms. There we go.
Thanks very much, Sarah. I'll just charge the microphone for some questions. I listened to that in trying to reflect on my own practice and thinking of myself as being a very open person and trying to embrace all the things you're talking about. But it strikes me, you said earlier on about people not caring about these things, and I've heard myself say, I don't care what your sexual orientation is and what you're in, trying to be positive. I treat you all the same, regardless of who you are and what you are and why you are. But that's a very passive way of doing this, isn't it? And that's what I just thought there, reflecting on that's not right. And turning from that passive acceptance, it's okay, is not really right. And I've got a clinic this afternoon, so I'll try and make a difference to my practice. I'm going to walk all the way there to Tom McDonald. Bear with me.
He's very fit. Thank you for an excellent lecture. I enjoyed that a lot. I wanted to ask your feedback on an encounter I had with a patient. And this patient was young and identified as male, but I don't know what the correct terminology is, was phenotypically female.
Okay.
and presented with iron deficiency anemia. And was the first thing that was uncomfortable for him was discussing his heavy periods. It had to be done. I had to discuss it. And it was a likely cause of his iron deficiency anemia, it turned out. So that was one thing that was a sort of uncomfortable thing for the patient. The uncomfortable thing for me was the patient was quite overtly flirty. Now, I know that I'm a stunning example of, but how do you suggest we cope with those difficulties? I mean, there has to be, the medical thing I think we had to be done, but what do you do if a patient flirts with you? It's quite hard to deal with, I find.
So I'll take the first point first because it's easier. So trying to use, I would say, using terms that are less female, so not talking about periods but talk about bleeding, because a period is a very female thing, and you kind of, with trans people trying to, or asking the patient, how do you refer to this? How would you like me to refer to this? I can see that this is difficult. Is there anything I can do? And it's important that we talk about it. Is there anything I can do to make this less uncomfortable for you? Because I can see it's causing you some discomfort. A lot of trans people do, not all, but some of them do have genital dysphoria, and so talking about their front passage might be easier, etc., than talking about their vagina. I think when you get stuck like that, addressing it, saying, this is uncomfortable, I can see you're uncomfortable, what can I do to make this easier? What do you call this bleeding that you get every month? I don't know if that's helpful or not, and it's very difficult to get a trans man onto anything that you label contraception, and you won't get them on anything that contains estrogen. You'll struggle to get them on anything with progesterone, even though it's not feminizing, just because it's a female associated hormone. You could get an IUS into them, a Mirena, a levonorgestrel intrauterine system to help manage that, although I'm getting off on tangents. We have had people self-expel a number of intrauterine devices because of the sort of hypertrophy you get of the uterus with testosterone treatment. Anyway, there's an aside. The flirty thing. Yeah. I mean, I've never ever been flirted with by a patient. I don't know. I think there's a... And I think when you know your patients and are comfortable with them, I think some, not all, gay men can be quite... I gave... this was terrible, though. I gave somebody, in fact, in the last week or so, I dread to think how many people I've treated for syphilis, but I was treating somebody for syphilis recently, and the injection's really, really sore, and I made the mistake of saying, and I didn't mean to say it like this, but it came out like this, I said, "You're taking that very well." And he said, as he looked over his bare buttock at me, he said, "I get told that a lot." And you sort of have a laugh. That's not flirty, and I didn't feel in any way endangered by it, but I thought I probably wouldn't say that again. I don't know, I guess it's just in the way that you put yourself, all you can be responsible for is your own behaviour. Obviously you have to be concerned for your safety if you felt somebody was overstepping the line. And of course if you felt that you're... so here's a situation. I did have to... I had a patient who... Here we go, this story. Who every time I examined him he had an erection. And I was getting to the point that I was really quite uncomfortable about it, and I did discuss it with a team of doctors because I thought, I don't know what to do about this anymore. I even had to do a biopsy on his penis, and I thought for sure this is not like the needle, whatever. I had a healthcare assistant with me at the time. Awesome, no erection. The minute she stepped out of the room to get me some silver nitrate, there went the erection, and I was just really annoyed about it. But I think we probably came to the end of our therapeutic relationship, and actually his care probably wasn't very good because I was looking for reasons to not examine him anymore, and that's not a good relationship. So you have to recognise when the limits of your therapeutic relationship have been met, and you can hand them on to somebody else.
You've mentioned syphilis now. So.
Oh, did I?
Yeah.
Oops.
I was just looking to see if there's anyone from the medical school. I mean, Susie's here, but unless you want to particularly address the issue about questions in medical school exams, because I can do that because I know that you're not shaking now. So we have been cognizant of that when I was in the medical school. We were cognizant of that sort of back to sort of 2012, and have made a real effort to try to insert into exam questions, both written and OSCEs, relationships that reflect more what the modern relationship mix is. So there are plenty of questions in the medical school question bank that say John and his husband come to see you in clinic because he's got a sore knee, and it's not because he's got gonococcal infection that leads to writers and all the rest of it. He's got a sore knee, so those things are in there, but I agree they're not there enough. I think they're probably in the minority. So we are trying that. We are trying. Does anyone else have any questions? We've got 23 seconds. So perhaps I just finish off by thanking Sarah for a really interesting and thought-provoking talk, as these talks always are, I think, in LGBT Month. And I hope that you found it interesting. It'll certainly change my practice. Thanks very much. Next week, Julie Christie from Gynecology and Andy Affleck from Dermatology are going to talk about writing to patients rather than GPs.